Our speaker this morning is Dr. Don Spivak. Dr. Spivak is a graduate of Wayne State University School of Medicine. He completed his adult psychiatry residency at the Detroit Psychiatric Institute and his child-adolescent fellowship at the Lafayette Clinic. He is a board-certified child, adolescent, and adult psychiatrist and a certified child, adolescent, and adult psychoanalyst. He was the director of the Children's Service at the Detroit Psychiatric Institute until its closing. He was the child-adolescent psychiatric consultant at the Oakland County Intermediate School District for 13 years and has provided consultation to agencies providing care to youth and their families in many settings. Currently, Dr. Spivak is the child-adolescent psychiatric consultant to the Detroit-Wayne County Community Mental Health Agency. He is a faculty member of the Michigan Psychoanalytic Institute. His private practice is in Birmingham. Please join me in welcoming Dr. Don Spivak.
Good morning. We're going to talk today about working with families to help them understand why you're thinking about a child's medication and how they can be a partner in the treatment of their children. So, first point I want to make is that parents are key players in their child's mental health. And to fill that role, they have to be well informed about their child's problem and about the treatments available for it. This involves asking the right questions and getting reliable answers. That is, you have to ask them the right questions and they have to ask you the right questions. There's all kinds of resistances to medications. You've probably run into a few of them yourselves, and I'd be glad to hear your stories and your experiences, and we can think about them together. When a parent is anxious about medication, a child's going to be even more anxious. Kids are anxious themselves, but if they recognize their parents' nervousness and anxiety about it, then they're likely to be even more anxious. There's a number of beliefs that people have that you have to help them overcome. One of them is that needing medication means the problem is more severe, that if I have a problem and I need medicine, I must be sicker. So if I don't want to be sicker, I just will say no to medicine. It's an irrational thought. There's a belief that emotional difficulties are different from other problems and only require the will or desire to change. That is, if you're depressed, you just have to get yourself up, pull yourself up by the bootstraps and move on, rather than you have an illness that may need treatment. It's difficult for people to conceive of the fact that their brain is one of the body's organs and that it can have problems just like other organs can. There's a fear that medication will make the illness known to others and that parents will be subject to censure or blame. So that if somebody knows if you have to have a child who takes medicine at school, then everybody will know their child's got a problem and they'll feel embarrassed or ashamed about that. There's fears about ill effects that they've read in the newspaper, they've read in the magazines, they've heard on the news that medicines are bad for children, that medicines cause problems, all of which are true, but they also are helpful. Every medicine you take has the potential of being harmful, but also the potential of being helpful. There's concerns about effectiveness. These are reasonable concerns, and we can't always say a medicine's going to be effective. We can only say it's usually effective, often effective, and can be helpful, but we have to see. There's a media coverage of problems associated with medications. You know that there was a big story a couple of years ago about antidepressants in children and that they cause suicide and more problems, and they shouldn't be used, they're highly dangerous. And you have to be armed with facts. The facts are that 3% of the people taking medication have an increase in suicidal thoughts. There's no increase in actual death with these medications. And this has been a well-known and understood problem that we have to pay attention to and look out for, but it wouldn't mean that you wouldn't take medication if it was likely to be helpful to you. So you have to know yourself what's out there and what's the facts so that you can help people understand that. There's fears of long-term effects on growth and brain development. These are, again, reasonable fears. We can only assure them with what we know by way of studies, whether it affects brains and how they affect them and in what ways they affect development, based on our current knowledge. So a lot of times medications come out, they're approved, that seem to be effective for certain illnesses, and then we find out after they've been out that they cause other kinds of problems and have to be taken off the market. There's nothing we can do except go with what the current research gives us. And then parents are worried about helping their own child overcome their fear of medication. Saw a kid just the other day who we talked about, he's had a long history of fears at night where he can't go to sleep without some obsessive listing of his fears and worries and having his mother sit with him. And I suggested him that medication may be helpful for that, and he was frightened of the idea of taking medication. Mother says, well, he doesn't take any medicine. He's scared of medicine just like he's scared of everything else. So I suggested to him that he do other things he might do, including some practice on reducing anxiety, and that if it didn't work, then he may come back to me and ask me for medication, but he should do what he'd like to try first so that he feels that he's an active part of the treatment. 2 days later, he called me and said, I'll take that medicine now. So, but it was based on his own coming to acceptance about that rather than his feeling that it was being forced on him or they had to take it against his will. A lot of parents have worries that if you put your kid on medication that they're going to end up using drugs because you're essentially saying to them, well, if you got a problem, take a pill. The fact, that's not an unreasonable worry, except that the studies show that kids who are actually taking medications, like stimulant medications, are less likely to abuse drugs. That is, the people who have attention deficit disorder, for example, have a higher propensity for using drugs because of their impulsivity and because of their difficulties in their social and emotional and developmental lives. But if they take medication that helps them with these problems, they're actually less likely to use drugs. There's an idea that medication only masks problems. I hear that from people who can't prescribe medication. They tell me, well, you shouldn't give medicine because it just makes symptoms go away, but you still have the problem. Now, there's something about that might be true. That is, if you have an anxiety disorder and you take an anti-anxiety medication and it works, you really don't want to worry yourself about what your anxiety was. You're not going to talk much about it. You're going to feel like it's taken care of. It didn't make your anxieties go away or change the nature of the fact that you have an anxiety disorder, but it does provide effective treatment. Some people who I've seen who take antidepressants for help often feel as though it reduces too many feelings, and then they can't really access their feelings at all. And when they can't access their feelings, they can't work on them. And so those people want to make a change in medication or reduce the dose. It's a question about the length of time about treatment. How long am I going to have to treat my child with this medication? And we have to answer honestly. It depends on the nature of the problem and what we're seeing in terms of the effectiveness, sometimes for a long time, sometimes for brief periods. People aren't used to medications that you have to take for a very long time if they haven't had a chronic illness. Mental illnesses tend to be chronic, especially the kids we're seeing with serious emotional disorders. They're not a short-term problem. But people are used to taking medications for a brief period of time to help with an infection. You take the medication, the infection clears up, you're all done. It doesn't work that way with these medications or these kinds of problems. People have fears that the medication will change their child's personality, or for the child, they're worried that the medication will make them different and leave them not in control. And that's the kid I was talking to you about who was nervous at nighttime. But we can help reassure people that's not the goal. The goal is not to make your personality go away. It's not to change you. It's not to control you. It's actually to give you more of a sense of control over yourself. That is, if you feel that you can manage your feelings better, you don't have to feel so frightened of your own self and your feelings. When we're thinking about medication, we have to start with a diagnosis. That is, it has to be clear about what you're treating. We're not just throwing medicine at kids because they come in and they misbehave. We're actually making a diagnosis. And you want to tell parents, how we're going to make this determination. First thing we're going to do is figure out what the problem is. What does your child have? And then we're going to think about what to do with that problem and how best to help them. And you want to inform people from the start. You want to help them be part of the process of being partners in the treatment from the start. What's actually going to happen? I saw a boy the other day. Mother had called me. She spoke to me for a long time on the phone about what her concerns were. She told me that she thought her son would want to see me first. He was middle adolescent, about 15 years old. So after getting the history, he came in and I said, what can you tell me about yourself? And he said, I'm 15 and I have a brother. I said, okay, but that's not a lot to tell me. Can you tell me anything else? He said, I don't know. What would you want to know? I said, well, you're here for a reason. Maybe you can tell me something about that. He was obviously reluctant. It came out very slowly. He had minimal information he could give me. What that tells me is that he really wasn't very well prepared for what was going on. He really hadn't decided himself that this was something he wanted, even though the parents assured me that he had said, no, I need help. I think they were grasping at straws when they said that. And so I brought him in with his parents and had them talk about what they were observing and what they were concerned about in front of him, and then included him in the discussion. What can you tell me about what they're saying? What have you observed yourself? What are you aware of? His parents said, well, we didn't want to tell you, when he was saying terrible things about you. And I said, but that was before he met me, right? And I said, okay, what did you say? He said, I'm not going to repeat them. They're just bad things. And I said, but was that because you really think that about me, or because you didn't know why you were here and what you were doing here? And he said, I was just mad because I was being dragged in here. I said, okay, so now you know, and now we can talk. And then he began a productive dialogue about what was the nature of his problem and whether or not he wanted help with it and how he might get help. And then he could agree himself to treatment. So from the start, you want to include parents and children in what's the process going to be. Because then you want to know, well, what are we going to do exactly? Are you going to give me tests? No, I'm not going to give you tests. We're just going to talk and try to figure out together what's going on. But I need your help, and maybe I can be helpful too. So you want to tell people what's going to be happening. How are we going to determine this diagnosis? Is it going to be talking? Is it going to be through test taking? Are there forms you have to fill out? You want to know what are the behavioral manifestations of the mental illness. We're talking about kids who have serious emotional disorders. So what is it that we're looking for, and what are we trying to assess? After you've made a diagnosis, then we're going to come up with a treatment recommendation. So you want to be informative to the parents. What exactly are you going to do by way of treatment? These parents of this child I was telling you about who wasn't too happy about being brought in, they said to me, well, what if, because we ended the interview with my saying to them, go home, think about it, and decide, and then let me know what you want to do. How do you want to proceed? The parents said, well, what if he says he doesn't want to come in? I said, then we have to go to plan B, how to help him without his being here. It will hamper us in our work, but we can still do work. We'll do work with you instead of with him, if you're willing as parents to do that, because often they feel helpless in the face of their child's problem. So I'm giving them a list of alternatives. Here's the recommendation. The first recommendation is I see your son in treatment. The second recommendation is that if he doesn't come, I see you. And then maybe together we can help him find his way to his own treatment and to recognize his problem. But I have to tell people, what are we going to be doing and why are we going to be doing that? Of course, for this purpose, we're talking about, in addition to psychotherapies, our medication is going to be part of the treatment regimen. Now, often you're thinking it might be necessary, but you have to make a referral to a psychiatrist for that evaluation. So you want to be very clear with the parents about how this evaluation is going to go. How long is it going to take to get there? How long will a physician be spending with you? What will they know beforehand? How will I have been informing them? You're not going to have to go through the whole process all over again. In fact, they're part of our treatment team, and I'll talk more about that later. Okay. So, assuming that for our purposes that medications are part of what we're recommending in terms of a treatment to a family for their child, the first question you want to answer, and that they should presumably ask, and if they haven't asked, you want to help them to ask, is what's the expected results and benefits of the medication? Why should I take it? In what way will it be helpful to me? What am I likely to see as a result of the medication? What purposes is it going to serve? Sometimes parents have unrealistic expectations. You give them a pill and then they become the good child that never gives me any problems and goes to sleep on time and never argues, right? It doesn't work that way. Actually, this medication, I tell parents a lot with kids who are taking medication for attention problems, this medication will help your child focus, period. What they focus on is another matter altogether. They may be perfectly happy to focus on a video game all day long, and they'll be very intent on that game. But that's all the medicine does. So you have to do something else beside medicine. It won't make them a better student. It'll just make it possible for them to actually sit with their work, if that's what they're doing. The second question out of parents' mouths is always, what's the side effects? What bad things will happen to my child? And so you want to be knowledgeable about that. What are the common side effects, and what are the uncommon ones? What things do they need to keep an eye out for? How soon will the side effects be evident? When should they begin noticing that? What should they be looking for when they're giving their child medication? Okay. How soon can they notice anything? For example, if I tell a parent that this medication may interfere with your child's sleep, I want to know, is it the first day, the second day, after they've been taking a week? When can I start seeing any results of the medication? And when am I looking at side effects? So often with antidepressants, for example, the first thing you notice is side effects, not main effects. It sometimes takes 2 to 4 weeks before you begin to see the main effects that you're looking for. So first thing you're seeing is dizziness and nausea and tiredness. And people say, this medicine is terrible. I don't want this medicine. It's just making me ill. So if you can tell people, all right, this is going to happen. It happens very commonly. It's going to go away. Just keep an eye on it and keep me informed about it. When we're giving somebody a medication, we should think to ourselves and to the parents, what is it that the medication should do? It should help children and adolescents feel better, concentrate longer, feel less irritable, angry, or hot-tempered, improve sadness, improve sleep, diminish sadness, reduce anxiety, be less impulsive, and other things that we're looking for with medication. What it should not do is make their child like a zombie. And if it does, if they say my child is flat and unresponsive and walks around like they don't know what's going on, then we've done something wrong. So it's not the goal. The goal is not to make a child like a zombie. Kids tell me all the time, I know kids who are on that stuff and it makes them like zombies and I don't want to be like a zombie. And I say, great. That's not my goal either. Zombiehood is not the goal for medication. And if it does that, then we've got to look up another tree for another answer. When you're prescribing medications, you want to explain why are we using this medication? What's the point of using it? How are we deciding what medicine to use? We're not just throwing darts at a dartboard and picking out a medicine. We're actually, have some careful thinking that we're doing about what the problem is, what's likely to help, how do we know it's likely to help? So you want to be able to explain to a parent, well, research shows. This is what the FDA approves the use for this. Now, often we're using medications the FDA does not approve because we're using them off-label. And then you have to explain that to a parent because some parents are going to look up in the PDA and they're going to see that, oh, this isn't recommended for children or for this problem, so why are we using it? You have to be able to explain, well, this is the reason, here's the literature that supports that, here's what I'm thinking about. I had a child with a tic disorder wasn't responsive to the usual medications, and there's some literature support for the use of an anti-seizure medication called Keppra. It's not huge support. It's only a few articles. So I can tell the parents, and I share the articles with the parents, this is the reason I'm thinking about using it. Here's the possible risks of using it, and here's the potential benefit, and here's the small support I have for it, for why I'm thinking about this. Now, what do you want to do, given that information? They have to be involved. And if they're involved, then you see, you decrease the likelihood that they're simply going to complain to you that you're doing this to them and you've done the wrong thing. When you make them your partners, then you're all in it together, rather than something that you're imposing on them. And you want to talk about your prior experience with the medication. Has it been helpful to other people? What have they noticed? When has it been helpful, and what are the problems that come up with it? You want to discuss openly and honestly what are the risks associated with the medication. What are the warning signs that warrant a call to the doctor going to the emergency room? That is, you really need to be specific with the parent, that if your child is doing this, that's a big problem. You got to stop the medication right away, and you got to give me a call. or give me a call first and then stop the medication. But here's the things that I'm most concerned about. So if you have a child on antidepressants and they start telling to you, all I can do is think about killing myself, okay, that's a bad thing. Call me right away. Let me know about that. Another side effect with antidepressants can be a sense of internal agitation, where it's like there's a motor running inside you and you can't shut it down and you can't feel calm. That's also a reason to stop the medication. And I'm very specific with the parents. Which are the worst things you have to look for and be on the lookout for? Now, sometimes parents don't want me to say it in front of their children because they have children who are likely to tell them that they got everything. But I have to negotiate with them that, no, I need an informed you and an informed child, because if your child doesn't know what to tell you, they may think, oh, this is just the way things are. I'm just supposed to feel like this. I had a child who was put on stimulant medication, and he told me that every day he felt sick to his stomach and it was miserable, but he figured that was what the medicine was supposed to do. And I said, really, you actually got to tell me these things. Because no, the medicine's not supposed to do that. It may do that, but it wouldn't be the goal of the medicine, and it would be a good reason to try a different medication. A parent should know, when will I report my observations? That is, when are we going to meet again, and are you going to be asking me, are we going to be following up on these questions? So I can tell you what I'm observing. I tell parents, this is when we'll meet again, and this is what I need to hear from you. So in the next 2 weeks, for example, I want you to observe this and this and this and report back to me. And I tell it to the kids too. This is what I need to hear from you. So try to pay attention to yourself and let me know, because the more information you give me, the better I can be about thinking about what to prescribe and how to prescribe. There's things we think people will just know, like what time should I take medicine? They actually don't. They don't know when they're supposed to take it. They don't know how they're supposed to take it, whether they should take it with food, not with food, how often they should be taking it, and you have to be very explicit. We write it down for the pharmacists, and we assume that the pharmacist will communicate. All these things don't happen. When you say take it in the morning, they say, well, what if my kid wakes up at noon? Because that's what they do in the summer. So it's not the morning, so that means I shouldn't give it to them. These are good questions to ask and to answer and to think about beforehand. So you want to be very explicit. Here's when the medication needs to be given. Here's why it needs to be given at this time. Here's what I would do or wouldn't do if you missed a dose, for example. All those questions that you have to review. How long will the medication be used? How will we stop the medication? If we're going to change medications, does it need to be stopped gradually? Can I just stop it all at once? What's the risk of stopping it all at once? What's the benefits? How should I do it? Is there a plan and a program for stopping it? They need to know all these things. Can other medications be used with this medication? A very good question. And it's important that you know, what are the medications a child is being taking? Are they taking allergy medications? Which allergy medications? Is there a potential risk for extra side effects if you take it with the medication you're prescribing? So you want to make sure you have an accurate history of what kinds of medications. And then every day people come up, can I take aspirin with it? Can I take antihistamine with it? Can I take steroids with it? You want to know all these things and make sure that they've asked them and that you know what medicines there are. What happens if the medication stops suddenly, I mentioned. How will the medication be monitored and by whom? You want to discuss with this parent. Who's going to be watching this medicine? Is it going to be the psychiatrist who they see once every couple months? Is that how it's being monitored? Is that all the monitoring that will be going on? Who else will be monitoring the medication? And how will they know what's going on? And how will they know whether or not there needs to be a change in the medication? And what's involved in monitoring the medication? Is it simply observations? Do you actually need to take blood pressure? Do you need to measure people? Are you checking for height and weight? Will you be doing blood pressure? Will you be drawing bloods? Do you need an ECG to check the effects of the medication? You should be informed about this so that you can inform parents. Sometimes the choice of a medication is based on what I'm going to have to do to monitor. If I tell a child who I think has a bipolar disorder that we might consider lithium, but here's the thing about lithium is that we have to monitor it closely and we'll have to take blood tests periodically, kids say, whoa, no, no needles, never. Give me one that you don't have to take my blood. And I have to take that in consideration as part of the thing that, I'm going to have to work with them about. If I think it's the best medication, I may decide that, we have to do it anyhow, and we're just going to have to figure out how we can do it. If I don't, and I think there's an alternative, I'll tell them, okay, let's try an alternative first. Let's see with something else, because they should know what is the nature of monitoring, and how often does it need to be done, and who's going to be doing it and where. If you tell somebody that, we need to monitor your child's weight, they may be very agreeable. Yes, we all need to monitor my child's weight. But if you haven't set up how is this actually going to happen, who's going to be weighing the child and reporting to whom about that weight, then you're not going to get the information. We want to be able to tell parents, how does the medication actually work? Now that isn't always easy, because we don't always know how the medication works. We have an idea about what it is that it's doing in the brain. We don't know exactly how it's effective. And we have to tell parents, these are the limitations of our knowledge at this point, but this is what we think is going on. They want to know what form is likely to be most successful. Now, some of that has to do with what your child's likely to take. If your child doesn't take pills and won't swallow pills, they want to know, is there a liquid available? And you should ask these questions before a child gets a medication, because if you write for a pill that they're never going to put in their mouth, you're not helping them. If I write for a pill that has a big capsule that a little kid looks at like, oh my God, I'll never swallow that, they're not going to take it, and then the parents aren't going to get into it with them, and nobody's going to bother telling you that the reason had to do with the form, and if you knew there was another form available, that could have been short-circuited to begin with. People ought to know how important timing is in administering the medication. Do you have to take it 8 hours apart? Can you take it, twice a day? Does that mean 6 in the morning and 12 at noon? Does it mean you can take it 6 in the evening? When should you take it and why? What's the point of taking it at these various times? And do I have to if my kid overslept and I didn't give them the morning dose, should I still give them 2 doses? These are good things to think about beforehand. Can I be taken with food, or should I give it to them after eating or before they began eating? For example, kids on stimulant medications often don't eat well during the day, so we want them to have a good breakfast and we want them to have a good dinner if they're not going to eat lunch. So you probably want to give them the stimulant medicine after they've had their breakfast rather than before. Now, some medications, if you take after eating, they don't get absorbed very well, so you have to know. Which one should you not do that with? Which one should you make sure you took on an empty stomach? We have to let people know that consistency of dosing is crucial. If we're telling you that a medicine has to be taken at this time, there's a reason for doing that. And if you're inconsistent with your dosing medication, it's very hard to assess its effectiveness. So if you say, well, I give it most days, but it's a medication that's required every day, then you're not going to get an accurate assessment about its effectiveness. I tend to get very specific about when people should take their medications and how they should think about doing it. So you have to make medication part of your routine. Some of you may be on regular medications for blood pressure and the like, and you've devised ways to remember, because otherwise you don't necessarily remember. I tell people you usually remember to brush your teeth at night. So put it by your toothbrush if you can take it at night, so that you're looking at it at the same time you're brushing your teeth. Let's do something that will make it part of your routine, so that it's remembered every day. It's important for parents to be actively involved in ensuring that their children are actually taking their medication and that they're monitoring how the medication is being used. I had a dramatic example of that one time with parents who said, they had an adolescent boy, so they wanted him to be in charge of his medication. But he had a history of suicide gestures. And so his managing his medication meant that he was keeping it until he had bottles filled, and then he took it all at once. That was not a good choice on their part. And I had to say, listen, I can't prescribe you any more medications unless you tell me you're going to lock it up and actually going to be the one giving it to him each and every time. And if I don't have your guarantee on that, I'm just not going to write it. I recommend regularly that people buy pill containers, the little plastic ones. They're like $1.79. And if you put your pill, your medications for the day in those things, you look at it and you say, oh, I didn't take it today because the Monday pill is still in there. So I know I have to take that. And if I check it, I put it in there every day, I know what I have to take. If you give them bottles, they look at it, I think I gave it, maybe, and then you get a call about, I think I may have dosed them twice today because I'm not sure. It was sitting out. I thought they took it. I didn't know. I ran it to school. They said they took it. I didn't believe them. And then, so to me, just lay it out every day. You can look at it. You can see it's taken, not taken. It makes it a lot easier. In fact, I recommend that we give it out to people, that the agencies have that as part of, here's your prescription, here's your pill bottle. Bring it back with you when you come back next time. One of the questions people have is my child going to develop a tolerance to the medication? I hear that a lot. They're on stimulants for a while, and then they get a tolerance to it, and it doesn't work anymore. That's not true. Actually, you don't develop a tolerance to medication. It may not be effective forever, and you may have to consider changing, or you may have to change the dose because the child's changed. They've gotten bigger. Kids grow while we're seeing them, and their needs for medication may change. How often does the dose need to be changed, and what are the criteria for changing it? That is, why would you change the dose of medication? And that includes up and down. So a patient who was taking an antidepressant at a particular dose, he found it useful and effective. At some point he came to me and said, it's been good, it's been helping me, but during the summer I'm under reduced stress. I really don't think I need quite as much. I also find myself eating too much, which is a common problem with antidepressants, so I'm wondering if I can reduce the dose and see how that goes. I said, yeah, let's try it. That's a good time to reduce it, to see, can you use less medication? That would be great to find out. People ask, is it a good idea to stop the medication going on a drug holiday for a time? What are the risks and benefits? Well, for most antidepressants, you don't want to go on a drug holiday. Either use it or you don't use it. And usually at this point, our recommendation is that you stay on for at least a year on the antidepressant medication. And then you stop it to see how it's going to go. But it's not something you want to take a holiday from. On the other hand, stimulant medications might be a good idea to stop if you don't need it to concentrate. If your summer is a relatively unscheduled, unstructured event, and you don't have to pay close attention to anything, and your impulsivity is not a huge problem, that is, you're not jumping off of trees and riding your bike over cliffs, then it may be a good idea to stop the medication over the summer and to give yourself a break from it, because they all have effects on the body, and if you don't need it, it's fine to stop it. But you have to be very clear about what would be the reasons for stopping the medication and what should we be on the lookout for if you stopped it. What kinds of problems might you see emerging, and then how will we know to restart it? There are developmental issues that we have to take into account when we consider medication. And this is not just about choices of medication, like I'm talking about when we're thinking about how much a child is involved. Their involvement, as I say, is crucial, but how involved they are really varies with their age. Adolescents want to know more about medication and what's going on, and younger kids say, my parents are in charge. I try to keep them informed, and I actually need their own reports to me about what they're feeling and how they're experiencing it. But they tend to leave it on to their parents, as that's my parents' business. Adolescents have different kind of resistances, and sometimes it helps if they know somebody else who's on the medication. I have adolescents come to me all the time, and they tell me, I don't want that one. My friend's on it, then it's no good for him. And because they go to the real experts who are their peers for all their information. And so sometimes it helps if you know a peer who actually was benefiting from medicine to talk with them. And it may, in fact, if you're in an agency where there's a number of kids on medication, it's not a bad idea to think of having a group to discuss medication and its values and its benefits, because they get a lot more support from their peers than they do from grown-ups. They think grown-ups are just out there to control them and put their authority over them and give them poison and things like that. But their peers really know what to take and why to take it. And I have kids who come to me and say, well, my friend is on this, and so I want it too. I said, well, do you have the same problem? Or do you know why they're taking it, or just for the heck of it? I had a kid I'm seeing now, and he takes stimulant medication, and his parents want him to take more than he's taking, and he wants to take less than he's taking. So we're negotiating, well, why would your parents think that it might be helpful, and how is it actually going for you? And they want him to take a long-acting because they say he often forgets to take a second dose, and then he remembers around 6 o'clock when he's not able to do his homework, and then it's too late to take a second dose. So if he took a longer-acting one, it would just bypass that problem, which is all very fine and good, except if I don't have his cooperation, he's not going to take it. So he has to be on board with that plan. Adolescents, they need to understand, why am I doing this, and how am I a part of this process, rather than is this being imposed on me and you're making me do something. And they need to understand the risks, and they need to be monitored for abuse. If an adolescent comes to me and says, I need my stimulant medication, and I look at the date and I say, you're a week early. So yeah, I don't know how that happens. Well, how it happens is that you take too much. That's how it happens. So I have to, sort of talk to them about, listen, you can't abuse this. You can't misuse it. You can't be sharing with your friends. You can't offer to, give them some of your medication because it might be helpful to them. This is me prescribing to you, so it's an agreement you and I have, and we have to work together on this. And if we can't have that agreement, then, I really can't treat you. And medications can be misused. Even if they don't get high from them, they think they are. So they will, misuse them just for the heck of it. And you have to be attentive to that. I mentioned that there should be a treatment team, and then the parents, the family, and the child needs to know who is on that team. Who's actually part of my treatment team, who's helping me? Is it the therapist and the doctor? Is there a nurse involved who will be monitoring, for example, the blood pressure and weight and height? Is there a physician? Is there a caseworker or a case manager? And who else? Will you be communicating with the child's pediatrician? Very important question. You should be. You should make sure that the pediatrician knows that the child's on this medication, because what ends up happening is that the pediatrician is prescribing some medicines, the psychiatrist is prescribing something else, and nobody's actually talking to each other. They don't know what's going on. So it's crucial to have open lines of communication. The parent and the child to the therapist, the parent and child to the physician, the therapist to the physician, and the physician to the therapist. Now, I don't know how much that actually happens in the agencies, but I think it's really important. You ought to know, why is the psychiatrist? I often hear from a therapist, I sent the patient to a psychiatrist. I said, okay, what happened? I don't know. I think they got some medicine. Okay, that to me is, that means you're not being as helpful as you might be. So what happened in the psychiatrist? You're going to hear from a patient. They saw me for 15 minutes and, they just gave me this stuff. I don't know why. Right, the physician has got a short time. So you're really the main communicator in that case. You want to know, have you given the physician adequate information to help them make their decision? Have they told you what their thinking is? Have they clearly communicated that? I'm reviewing records, and I'm looking at the physician notes, and I say, they gave somebody medicine. It's not clear to me that they've explained exactly why and what their thinking is and what they're going to be looking for to know, did this work or not? If you know that, then you're likely to see the child a lot more often than the psychiatrist is, then you'll be an important part of that team, and you can help the parent be an important part of the team. Parents need to know, how often will you all be communicating to each other? You're going to be talking to the physician about the medication? How often will I be talking to you, and how often will you be talking to them? So if I tell you, I think my kid's having a problem with this medicine, will you just say to me, okay, make an appointment, and then I'll know I'll see them in a month? Or will you help facilitate, my getting my question answered sooner? How will you be involved in that? I think that we need tools to help us in our work. And I think it's really crucial that the therapist and the parent have an information sheet about every medication. What medication is your child on? The brief, not the long sort of story that they're not going to read anyhow. Bullet points. These are the things, the main effects. These are the main side effects. Call me if. And then included in that sheet should be, the side effects, behavioral changes, and medication-specific notations. That is, I think we should ask the parents for a reporting sheet. Bring this back with you next time you come. What happened? What did you observe? Were there any side effects? Bring it back so we can discuss it. And if they don't bring it back or they bring it back empty, then you sit down and do it with them because you make it clear. This is really important. I mean, we're not just throwing things at your kid and hoping it gets better. We're really looking for very specific changes. And we want to know, is it effective or is it not? And if it's not, do we need to make a change? I've noted here some on the bibliography. Some books. The second one, Helping Parents, Youth, and Teachers Understand Medications by Nina Dolkin, is really a tool book. It actually lists all the medications and gives you, it has a disc in there that you can print out information sheets. So I'm recommending that just because it's very useful. It's got short, brief explanations of what the medicine is, why it's being used, what you should be looking for. And I think that's a good model. You don't have to use that one exactly. You can use your own version of it. But I think that if you feel informed and the parent feels informed and you make them an active part of the treatment in terms of give me the information back, I'm going to be asking you regularly, and I can use your report sheet to directly give to the psychiatrist who will then have all the information they need to help them make informed decisions. And make sure that the parent knows, when will you be talking about this medicine again? When will you be looking at it? How are we looking at it? What are we reviewing? What are we thinking about when we're seeing the medication? Okay. So mostly what I've done today is given you 100 questions that you want to consider. I hope that there are things that actually will help you think about how to be an active part of a child's medication so that you can help the parents feel like they're real team members in the treatment of their child. That they are an active part of the team. It's not just a matter of signing off on the form. It's a matter of really being a decision maker and an observer. This boy I was telling you about too has trouble going to sleep. So his mother, every single night for 2 years, has been sitting in his room for half an hour answering obsessive questions about whether or not he's going to die, whether there's any illness, whether she's his real mother, whether there's any fires anywhere. And they go through it, and it's a very routine list. And I said to the kid, your mother has been helping you every night, but she wants to get out of the job. Well, I said, not out of his job, parenting. But I said, yeah, I know, you want to get out of his room every night. You want him to feel like he can put himself to sleep without going through those questions. And I said to him, and you want to feel like you can go to camp, because he tried to go to camp, but he'd have to call his mother on the sly every night to answer the question. So he said, okay, right, I want this. I said, fine. If we're all on the same page about what you want, then we can think together about how we're going to approach it. And we're going to try different methods, and we're going to see which one works most. But you got to tell me about it. You got to tell me, is it working? It's not working. It's helping me. It's not helping me. It's helping me this much. It's helping me this much. And how will we know if it's helping you? There's actual ways of knowing that. We're not just, it's not magic here. We're really looking for specific things. And if you know what those specific things are, then you can tell me what you're observing and what you know. That's the same is true for stopping medicines. A kid who was taking stimulant medications, and I actually didn't think he needed it, but his mother thought he needed it and had convinced him, and he was convinced he needed it. And he was very religious about asking me. The biggest problem he had was anxiety, and that's so he was anxious that he had to have his medicine because his mother was very anxious along with him. At some point, as I began questioning, do you really need this medication? Is it really helping you? He said, well, how will I know if I don't need it? I said, well, you could try not taking it. You could do that. He said, but my mother will go crazy if I don't take it. I said, does she always know? Because let's run an experiment. I said, you can take a spelling test with the medicine and then take it 1 week without the medicine and tell me how you do. So he signed up for the experiment and he reported back, I got the same grade both times. I didn't really need the medicine. I'm not going to take it anymore. I'm going to see how it goes. And even if my mother thinks I need it, I'm going to talk to her about it. Okay, so that was a process together that we worked on. That, okay, there is criteria. You can examine it, and you can think about it, and then you can know, is it useful to me or not? Do I need it? Is it helpful? What are the problems if I'm taking it? Okay. Any questions yet? Or it was so completely clear? Maybe you can, tell us about, your experiences with the process and where their problems are. Was trying to think beforehand, what kinds of problems might people be having in this process, but I'd like to hear from you. Yeah, hold on until they bring you a microphone, okay? Over there? Is there someone with a mic? There's a microphone over here. Okay, we'll take this question first. Then we'll get over to you next.
When you're working with parents, they have a lot of anxiety about putting their children on medications. How do you deal with the attention that's been given to the lack of research with medications on children, that most of the studies have been done on adults? How do you address that with a parent?
Well, I tell parents the truth. There isn't a lot of research done with children, although we're doing more now than we have in the past. They can certainly understand why we're not doing it, because nobody wants to sign up their kid for taking a medicine if they don't need it, and people are more reluctant to do that, so they understand that. They don't want their child to be a guinea pig either. I tell them, this is the best information we have right now. There's good, it is used. I'm not giving you something that's never been used before. And here's as much information we have so far. Most of the medications now, there is a bigger push to study them with children. So we do have more literature than we used to have about the effects and the ill effects. And I tell them that. I also encourage them to, I give them websites. I tell them, where they might find more information on that. I really ask them to be an active part in that decision process. So it's the best you can do. I mean, it's clear why we don't do a lot of trials on kids. Who's going to sign their kid up to take a medication when they may not need it, given that there may be ill effects. There was a question over there if you have the microphone.
Good morning. My question is involving the medications and not making the child feel like a zombie or agitated or confused.
Yeah.
Oftentimes, some of the children are feeling this way as a result of the side effects, and when this information is presented to the psychiatrist, the medication may or may not be changed. Now, in the event that the medication is not changed, does this mean that the dosage was too high, and how could I advocate with the consumer or for the consumer with the psychiatrist?
Okay, that's a great question. That's exactly what I'm talking about, being part of the team. The parent says, I said to the psychiatrist, my kid's like a zombie, and they didn't do anything about it. And I'd say, okay, then we have to sit down as a team. Tell me what are you actually observing? Let me talk with the psychiatrist. Let me make sure that that was clear. And let me help you hear from them why they're continuing in the way they are and what they're doing, what their thinking is with that. So let me facilitate the communication, because it's a communication problem. I mean, obviously, a psychiatrist is not looking to make a kid like a zombie, and either it wasn't clear to them what was going on, or they thought really it's going to stop and go away, or, we don't have too many choices because we have to do this right now, but we may change it later. All those things are going to be part of something that may not have been clearly spoken in the short time that they were able to see them. So this is why I think that you as a therapist have to be an advocate for your client, but an advocate within the team. You have to make it clear we're not opponents here. We're all on the same team. So if there's something that you don't think was clearly communicated, that's exactly why we have a team. And we're having a team meeting. It's coming up at this time. And if we don't have a team meeting coming up, I'm going to make sure that I've written down your concern. Here's what I would say. Does that fit your concern? And I'll get back to you next time you come in about what the answer to that question is. And if you need to schedule more time with a psychiatrist to answer your questions more clearly, let's do that. That is to make them clear that you are interested in communication, you're interested in having their questions answered, and that it's not like you just do what the psychiatrist says and don't bother with it. That this is important for you to have those questions and observations, and it's important for you to share it, and I'll be sharing it with the team. Yes?
My question is, when kids are first prescribed medicine and parents want to know how long are they going to be on the medicine, what's the likelihood of the medicine being discontinued? Because in my experience, I've seen antidepressants be prescribed for a long amount of time. So is there a statistic that shows 2 years, maybe 3 years, or what do we tell parents when they want to know how long are they going to be on it?
Well, what you tell them is the best information you get from your psychiatrist, but because you're not determining that, but you can say, well, I've talked to a psychiatrist who tell me that usually when we prescribe antidepressants, we're at this point, we're going for at least a year, sometimes less, but it may be more, but maybe after a year you'll reassess where are we at and should we take a time back away from it for a bit. On the other hand, people ought to understand that we're talking about the mental illness which tend to be chronic. That is, like diabetes, it tends to be a chronic illness, like a high blood pressure. It's nothing, you don't treat high blood pressure for a few months and then stop. You keep monitoring it, you see where you're at, you may have to increase the dose. The same with mental illness, that is, if it's an effective medication and it's a chronic problem, then you may have to treat it for a long period of time. But what I say to parents is that how we will determine that is based on what you're reporting to me about what you're observing. If you're observing, like my patient said, I want to reduce the dose of my medicine. If you're observing, things are going pretty well for me now. I haven't had a lot of anxiety or unhappiness recently. I'm feeling pretty good. In fact, I'm feeling like the medicine may be stopping me from feeling better. And say, okay, well, let's see. Let's try stopping it. But here's my initial thinking about how long you'll take it. That may change over the course of the year, depending on what you're telling me. So I think that before you answer the question about how long anybody's on medicine, you have to make sure that, let me talk with our team about that. Because let's be clear at the outset, what are you thinking when you prescribe this medication? Are you thinking short term? If somebody's coming in for a grief reaction and they're unable to sleep and they're preoccupied with thoughts about their lost one, I know that that's not going to go on forever. And I may prescribe an anti-anxiety agent very commonly for a short period of time. I'll tell them this is going to be for this period of time, and then if there's continuing problems, we'll consider something else. But often what we're talking about is long-term problems that have been around for a long time are going to continue. And more than anything, they need not no medicine or medicine, they need changes in medicine and adjustments in medicine. Yeah. Oh, over there.
Good morning.
Hi.
Have you ever had within your practice anyone who has chosen to use homeopathy or naturopathy, and then you find out that you're giving the hard drugs, if you will, on top of that, and how do you address that with parents?
Oh, yeah, that's pretty common these days for people to do something pathy. I have in my office a handbook of herbs and other things, and I review it with the parent about, here's what you're using, here's what the risks are, here's what the actual studies are. Do you want to continue using it? People use melatonin for helping with sleep. That's actually a good choice. It often does help people sleep. So if people see that, I'm not opposed to whatever they do, so long as we both understand what the risks and benefits are and whether or not the medications will have any added effect or change anything. I'm happy if people find something that helps them. But it should be a thoughtful decision on their part. If people are taking kava, which was touted as something that's supposed to help you with anxiety, the facts are that in the recent studies, it makes people more agitated, and it can make things worse for you, so you ought to be careful about that. But I share the studies and let people make their own decisions. If I think that my medication will be harmful because of what they're taking, I won't prescribe unless they tell me that they're actually going to stop. And how do you know? I mean, you just have to trust people. You have to work on a trusting relationship. I always ask people, what things are you taking prescribed and non-prescribed? Because it's surprising what people take and what they think they're using. If you don't ask them, they don't tell you. It's a good question, thanks. Yeah. First here, there.
Good morning, thank you. I'm looking for suggestions on families who their child starts taking medication and they're totally for it until the child may have a negative change in behavior. Then all of a sudden, it is all the medicine's fault. my kid didn't do this and still that darn medicine, this. They talk about it in front of the child. Then the child has an excuse for all the negative behavior.
Yeah.
And they don't want to try anything else because, oh, he wouldn't do that if he wasn't taking the medicine. And then if maybe the psychiatrist would take them off the medicine or start maybe dosing down the medication. And then it's still the medicine, or now he'll continue to do that. What can we do to not maybe judge the family or tell them what we think, or that we're all about taking medication, but to try to help them think that it's not just the medication that's making this behavior change, or to get them to stop talking about that in front of the child.
Okay, good question, but I think that that's the point of my talk, is that the more informed they are to begin with, the less likely they are to come in with blame. That is, if you say beforehand, these are the likely problems, and these are likely effects. If they come in with something, well, my child never misbehaved until, they took the medicine, I'd say, wow, that's new. I may have to report that to the FDA. And I'm got to tell you, I'm not truly convinced that it is the medicine, but I'm willing to go along with you on an experiment. Let's see what happens when we stop it or change it. You'll have to report back to me on, was there a real change? Because here's what I think. This problem was part of the whole problem he came in the first place, and the medicine just isn't helping him with it. On the other hand, people do change behaviors when they take medications. If you take an antidepressant like an SSRI that reduces some of your anxiety, some people who have been controlling their behavior on the basis of anxiety no longer feel the need to control it. That is, they're not so scared about what will happen if they do something. And so they may behave worse. And I have to consider that when they're talking to me. Now, what I would say to parents is that, it seems to me that your child is reacting as though they don't have to take responsibility for their behavior, instead of recognizing that we're all trying to really closely observe how the medication works. Then you help the parent become your partner in that, and in helping them to talk to their child. Look, you can't blame the medicine for this. It didn't really cause that problem. You were doing that behavior before. But to me, the best prevention for that is to make them active treatment partners from the start, including feeling well informed about what they can expect.
When our people that we support switch to a new psychiatrist, they automatically cease the medication regime that people are on. And the parents calling me back and saying, why did they do that? And I don't know if you can answer that question, but why did they automatically just de-cease all of the medications and start on a new medication regime? Yeah,
it's a bad idea, but here's how it goes. Have everybody heard the question about changing regimes when you change psychiatrists? Often you're working with somebody who's observing that, well, this medicine's not really working. Now you're talking about an DD population, and I didn't talk too much about that, but the principles are the same. It's just that more often you have the parents who you have to rely on for all the observations, and kids can't really tell you as much, although, depending on their functioning, they can be participants. You're treating that child and you're seeing this medicine's not working, you end up using a whole bunch of medicine. You're trying different medications for different problems. And none of them are, in general, there's a tendency not to want to use polypharmacy, but clinically, often we end up doing that because we're trying to deal with different problems. You might be trying to deal with an attention problem and a concentration problem, as well as an aggression problem, as well as a sleep problem, and each one sort of works differently. So the first person is going to put them on all this medication. The next psychiatrist who comes in and says, "What's all these medicines for? I don't know what's going on. I need a clear field. Probably they're having problems because of this. So I'll just take them off everything, and then I can see what I'm going to put them on." And then, of course, you have a kid who's just bonkers. So again, to me, this is a matter of the physician in that case actually respecting the team. If the physician who's reviewing a case for the first time has good communication with the therapist and an adequate history, listen, you're going to wonder why is this child on all these medications, but let me tell you the history and why each choice was made, because I'm clearly informed, so I can make sure you know. Now, if we count on the parents, make sure you tell the psychiatrist. They don't do that. They don't even know what they're supposed to be telling. So unless we've reviewed with them, here's what you need to say, then I know that the psychiatrist is not going to be well informed. And if your records, go and read somebody else's record and tell me if you feel really adequately informed that you could just pick the case up and start and go. Our records are not that clear, but we need them to be. So if the physician who's seeing a new patient has a real adequate history, tried this, these were the effects, still having this problem, added this, have concerns about polypharmacy, but this was the justification, did this, then they're going to say, okay, I got a baseline. I understand why you're doing what you're doing. But maybe I have a new thought. The new thought shouldn't be just clear the deck. The new thought should be let's review everything and why you're on it and why you got there and whether or not it's working. So I think that's what happens. If you want my opinion, why it happens, it's not uncommon. People come to me with lots of medications. I say, oh, what are you on all those medicines for? And then they tell me, I said, okay, I got it.
Dr. Spivak, I've picked up a few question cards from audience members. The first of those is, what effects are you seeing, good or bad, with the rise of medication infomercials and also information on the internet?
Okay, infomercials, they're terrible. I mean, people come in and ask for medicine, which is actually okay. I mean, gives us a chance to discuss. And I like it when people are thinking about themselves and their medicines. The patient says to me, what about that medicine? What about that depression that helps pain medicine? I got pain, I'm unhappy. And so it gives me an opportunity to talk about, well, what is it really about and is it likely to be helpful or not? So I just find it terrible because people, I think, might be getting more medicine than they need because that's the point of commercials, is to make sure that people are taking it. The internet is filled with misinformation and limited information. The people who are most likely to write on the internet are people with complaints. So if you look up a medication and you find horror stories about what happened to me on my medicine, that's going to be easier to find than the positive results of the medication. I encourage people to bring all the information they have and let's review it together. To me, I don't want to discourage anybody researching it. I just want them to understand what they're reading and how they're reading it and where it's coming from. And I want people to make informed decisions. So I'm happy that people look it up. I'd rather they read the PDR than not read it. I'd rather they ask me the question. I encourage them to read it. I encourage them to go online and to tell me any questions they have after they've done it. If they don't, then they feel like they're doing something they're not supposed to do, and then they don't tell you what they know, and they stop their medicine based on something that they haven't been fully informed about. So it's best to keep it open. I like access to information. I'm glad that people are taking advantage of it. I just think they don't necessarily know how to evaluate that.
Okay, next question is regarding children under 5. And the person's asking if there's an age limit at which medication shouldn't be prescribed.
It really depends on the problem. There's no absolute cutoff for medications. But we have to be cautious with a younger child in using any medication because of their continuing development and the ways in which it might affect their development. So you have to use extra caution for younger children, but there's no medications that are absolutely can't be given below a certain age.
Okay. It actually leads to the next question. At what age will a psychiatrist diagnose a child with a serious emotional disturbance? And then a similar question is whether there are certain diagnoses not given until certain ages, and they specifically ask about bipolar disorder and ADHD.
Okay, well, bipolar disorder is increasingly recognized as being a disease of childhood, where some years ago it was thought that it would only occur after later adolescence, early adulthood. Now, as research is being done more carefully, we're seeing that, and if you talk to people who have the disorder, they know that they had symptoms and problems way before it was diagnosed. So it does occur in childhood. There's a big controversy in literature now about how young you can identify symptoms. There are children with symptoms that look very much like they're going to develop into bipolar at a young age, 3, 4, 5-year-old children who don't sleep or are constantly on the go. have periods of wild emotionality that doesn't seem really justified by the moment. And while it's difficult to make that diagnosis, it's something you have to keep in your back of your mind, is this is where it's going. And the question about medication is less based on the diagnosis there and then as it is to what are the symptoms we're trying to treat. Often I will say to parents, what we're seeing is a mood disorder. There's a difficulty regulating mood. I'm unwilling to call it bipolar yet, but this is part of what my thinking is and may be heading towards in the future. And a lot of times you don't know until you get the full-blown symptom picture. You're getting bits and pieces of it. How does bipolar look earlier in development? Well, if you talk to people who develop the full symptoms in young adulthood, they say, all during my adolescence I had periods of profound depression, but I didn't talk to anybody about it. I stayed in my room. And then there were periods where I just felt great and I was, on every committee in my school, and then I just started feeling bad. But they didn't bother, nobody noticed it. Nobody thought it was outside of the realm of, what might happen to an adolescent until you see how it develops further on. So I can't give you a clear answer. It really depends on the symptom picture and the family history. And often what we're doing is making a presumption about later development. And so we might be reluctant to make the full diagnosis, but you got to give a kid some diagnosis, so you give them the best possible choice. At this point, there's no age limitation to that diagnosis. The only diagnoses that have age limitations are the personality disorders. For example, a borderline personality disorder has to be diagnosed after 18. But those are the only diagnoses that I know of that have age limitations. Other questions? Yeah.
I've been working with deaf children and deaf adults for the last 15 years. I've really seen a lot of problems connected with communication. So I'm curious how you would suggest that parents who work with their child, if the parents can't communicate with them, there's about 90% of the parents aren't able to communicate with their deaf children. So how will the medication and the team intervention, how's that going to work for the deaf child? Do you have any suggestions about that?
Okay, well, there's the huge problem of communicating with their deaf child, period. One of the things we can teach them to be, though, is close observers. So we want them to be close observers of their child, and then they need to know which information are they looking for. What are they observing? And then comes the how to communicate that to their child. Often, they're not getting words from their kids because they're not good at talking with words. We're giving their kids words to use, but they can't observe their child. And you can give the parents what are the specific observations that we want you to make. So it is your child able to do their schoolwork? Are they able to sit still? For example, with stimulant medications. Are they crying less? Are they less frightened with other kinds of medications? And how will you know if they are? Well, there are specifics. A child goes to sleep on their own, less scared. A child is able to go to camp without hiding behind a parent behind, less scared. There are things that we're looking for, behavioral observations. But the problem with communication with their child is a big one because they're speaking two different languages. There's a child who's speaking, by talking, and then the child who's using sign. The parent, they're talking two different languages, and it's like the problem we have with anybody using two different languages, but you often miss information. It's best to make sure that the child understands as well as they can. My daughter works with deaf children, developmentally disabled deaf children, and she had to act as a advocate for that child when she was in the hospital. They would go in and just start poking her with things without telling her because they thought, well, she can't hear. And she had to say, listen, she is feeling and thinking and observing, and if you don't explain to her why you're doing what you're doing, she's going to sock you in the head. So you better, figure out a way to communicate and not just walk in like you can do whatever you need to do without ever talking about it. So the same with, any deaf child is that the thing you want to tell a parent is don't do something without their involvement. because otherwise you just frighten them, and then they're going to fight you. Yeah. We gotta wait for the microphone.
I'm pretty loud.
But they need it for the tape.
I think this might be covered by the whole umbrella of what you're speaking about, but you had said early on fears of will this lead to drugs of abuse and so on. And previously I worked with drug addicts, and 100% of them abused prescription drugs. And obviously they're a special population. Later on, you talked about how it's important to build a team, and maybe, I guess I'm just drawing the loop back to the drugs of abuse part, that the team needs to be built with the parents in the leading edge. How do you talk to them about securing and being careful with these medications in their home? Not that you want to assume your child is going to abuse these drugs, but how do you communicate with them in a way so that they will take ownership of the medication and not allow these young people to medicate themselves?
Right. I mean, that's a big question. It has to do with parental care taking in the first place. I mean, you have to make, as part of your team assessment, is what is the capacity of this parent I'm seeing? I'm asking parents to do a lot and not to act like passive victims to their child's problems or to my prescription or to anything, but to be really involved. Now, a lot of these kids are coming to us because their parents have terrible problems. They hardly can get them a meal, let alone make sure they have their medicine on time, which is why I'm saying that you have to be very specific and concrete about what your expectations are. I'm not just giving you this bottle of pills and then, good luck with it. I want you to put them in these pill containers. I want you to, pay attention to them. I want you to put it where your kid just can't grab it. And I want to know how you've done that. And you have to report to me, what steps are you taking to actually follow through on that? And here's the risks of you're not doing that. Many kids misuse it. They think a little bit is good, a lot will be better. Their friends are telling them, how about sharing that with me? Can you give me some of that? How about your parents' medicine? I ask them a lot of questions about where do you keep your medicines in your family? Who has access to them? Does anybody know where you have them? We had a kid in the system who killed herself with her parents' pain medicines. It turns out that the parents were drug dealers and had lots of pain medicine in the cabinets. And they also knew that this girl periodically acted in an impulsive way. So what would have been required? Well, there was an in-home treatment for this child, but apparently they hadn't gone through the cupboards and emptied them out until after the kid killed herself and said, okay, we're clearing out all your cupboards. So sometimes you actually have to take very active measures. I want, if it's an in-home treatment, a kid with a severe problem, go in there and say, okay, show me where you keep all your medicines. And show me how you've secured them. And here's a lockbox I can give you that only you have access to. Let's go to the store and buy it. Let's know how to put these things away. What are you actually taking care of? You'd be surprised what people have laying around that kids can get a hold of. And substance abusers abuse everything. So it's not because the medicine made them a substance abuser. It means that something has happened in their life that made it feel to them that the only thing they can do is take something outside themselves. And that's a problem. That's not the point of the medication. That's why I say to parents, listen, medicine is not a panacea. It may help with these symptoms. It may cause these problems. Let's see if it's worth it. And then be careful. Use it very cautiously and carefully, and don't misuse it from the start. A kid tells me, I take the stimulant medicine. I take 10 milligrams, to help me study, and then another 10 if I haven't slept. I said, okay, that's a misuse. I'm not going to give you number 210 if you're going to use it. Here's what you have to do is sleep. Because, it'll keep you up, but it makes you all wired, and then you're not really concentrating on your work. So you're abusing the medication each time you're using it to help you stay awake. So either you tell me you're going to get adequate sleep, or I'm just going to stop prescribing. And if you want it to help you concentrate, great, use it correctly then. But thanks for being clear with me about how you're using it, because otherwise I wouldn't know. And I tell it to, I have adults who are on stimulant medications. They tell me, if I don't sleep well, I take one of those because it helps me stay awake. I said, then I'm going to stop prescribing it because I'm not writing you wake-up medicine. I'm writing you concentration medicine. Okay. Yeah.
I wrote my question down so I wouldn't forget it. But just to preface the question, I'm wanting advice or suggestion from you about what therapists can do before we're even at the point of referring a child to the psychiatrist. What do you recommend therapists do when working with parents who are more on the flip side of fearing medication? Which I mean, the parents seem to be seeking medication to fix or cure their child, are ready, willing, just want to do that. When the presenting issues appear to be emotional, behavioral, specific to the parent-child relationship. And I'm kind of speaking from the perspective of especially when you're working with kids under 6, because that's the population I serve.
The warnings I give to people vary with what I think their purpose is. If I think that they're reluctant to take medication, but it's indicated, I will give them one kind of warning. If I think that they're looking for medicine when it's not indicated, then I emphasize the warning part, and I make it clear. Listen, you're putting your kid at risk, unnecessary risk, and while it may have some effect, I really don't think that's the main problem here. Of course, I am in a better position. I don't have to prescribe anything I don't think is indicated. And if you're a therapist and the parent says, I need this medicine, and you're going to refer them, the next thing you want to do is be, again, active part of a communication team. You want to make sure that when you've made that referral, you've communicated with the therapist, with the physician, your concerns, your doubts, your questions, and what you'd like to try before medication is used. Then when they go see the psychiatrist, the psychiatrist say, your therapist and I have talked extensively, and I have to agree that it's much better to try this approach because of the risk that we'll be putting our child at unnecessarily at this point. Now, we can re-examine this, and we're not telling you no. Now, when people go shopping and then go somewhere else and find somebody to write a medicine prescription. But, you got to do what you think is right. And the way to do it is by being an important part of a team where everybody's backing you up on it. I have that advantage because I'm the team, so I'm the therapist and the prescriber. I talk to myself all the time, and they have to go to someone else. But you have to actually communicate. You don't just make the referral thinking, well, I hope they see what I see. You have to say, here's my concerns, here's what I'm observing. I really think this is a problem between the parent and the child. And I don't think it's going to be helped with medication. In fact, I think that they'll sort of act like they had nothing to do, but the only job for them is to give medicine when there's really important changes that need to be made in the family. And, you can get a psychiatrist who's going to back you up. And then you have two people talking about it. Yeah.
Sorry. That's actually a good segue for my question. I also wrote mine down too. Seeing as you're a psychiatrist, obviously, and an analyst, I was interested in knowing how you kind of address that therapy piece, because there's a lot of parents who, once they get the meds, they're like, okay, no longer need you, just need to see the doctor. So I'm wondering, even though you're both, how you address that.
Okay. What I tell people is that the literature supports that the most effective treatments are psychotherapy plus medication for the problems. And that's true for almost everything that we're treating with medication. That the best help will be from the talking part as well as the medication. But there are people who just want medication and for whom it's effective and who I don't see otherwise. I really just see them because they want to tell me how the medicine's working, and I want to hear about it, and then we're all going to agree, and that's fine with them. And then there are people who want to talk about what it is and isn't doing and what else they need to do for themselves and really understand that other interventions are needed. So it's not a hard and fast rule for me. I tell them what the best treatment recommendation is, and I encourage them to be part of that. But again, it goes back to making them part of a team. We're a team here. Here's my best recommendation. What part of the team are you going to be on? And where are you going to play your role? And if they say, my only job is to give out the medicine, and I don't want to have to bring them here, and I don't want to talk about anything, I say, okay, either I can agree or not agree to treat them. And sometimes if they're just interested in medicine, I don't want to. I don't want to spend that much time doing that. If they're interested in actually working together while they're on medicine, then that's a better interest to me. I wouldn't take offense. If somebody was helped by medicine and that's all they needed, I'd be glad. It gives me more time to see somebody else who wants to talk. I don't feel proprietary in that way. It's only a matter of if you really think they need talking, and that's, that they're avoiding important things by saying it's just a medicine issue, then you want to talk to them. But the best way to talk to them is to have everybody on the team agreeing on that, and agreeing on what's the process for that. This kid who came to me, and first he wanted some cognitive behavioral techniques for helping him with anxiety at night, and then didn't after 2 nights. I think his mother didn't, because she was ready for medicine. I will say to them, listen, the medicine's likely to be helpful, but it's not, you got to tell me if it's really doing everything, and if it's not, we got some talking to do. And I hope I can, sign you up for that. But sometimes the way to sign them up for the talking is to be cooperative with what they want. And then they say, okay, I have control over my treatment, and now I see, the meaning of what you're saying. Yeah. It's coming.
We're talking about the importance of the team approach. I work with a DD population, and I venture to say probably 50 to 60% of my kids are on medication, but I never have a psychiatrist consult with me.
Yes.
When it's about the kid having problems in school. And my efforts to contact the psychiatrist to give feedback, it's hard to get a return phone call. So you're a psychiatrist. Do psychiatrists actually take that into consideration, consulting with the teachers, the caseworkers, when they're servicing kids, when parents come to them about problems that are occurring in a school setting?
Do they? They
regularly, is that a
are
part
supposed to. They're trained to. Now, do they have time? Let me tell you about my
Yeah,
schedule.
I hear about the times.
I get a call, and sometimes I get to make a call back by 9 o'clock at night, and sometimes, I've had it, and I can't get to them, or I call back and they're not available at that time, and then it means I have to keep making calls. So it's not always easy to communicate. Now, I think when we're talking about an agency, it has to be part of the agency policy that there are team meetings, team discussions. And I was hoping that some psychiatrists would be here to hear about what their role is too, and so that they understand, they're an active part of the team. It's not everybody else's work and they just prescribe the medicine. From a psychiatrist's point of view, all information is necessary and helpful. I don't proclaim, I don't see this kid all the time. I need close observations by as many people as can do the observations. I often rely on parents to do that. That means training them to get all the information I need, because I don't want to take over their parental functioning. But often, it's best to get the information from the person themselves. I'm happy to get information from anybody in the family. I got a call from a mother of a 50-year-old guy who said, I don't know if you know this, but he's not reacting well to this medicine, and he may not be telling you. I know you can't tell me anything, but I can tell you. I said, yeah, great, thanks for the help. A family consulted me about their son in another city who had a bipolar disorder, and they said, we're observing this, and the psychiatrist, I don't know if he's really aware of what's going on. I said, call him. They need that information. So is it something? My point is that it should be done. If it's not happening, it's an agency-wide problem. It has to do with, what are the expectations of the psychiatrist? And that includes what are the agency's expectations, because they may be slamming that psychiatrist. So, and if they're slamming them, then, that person doesn't really have time. They're hoping to get the information in the chart that they're reading, and if they can't, they're just going to go on their best judgment. And that's unfortunate. It means we're not giving the best help to the people. So that's an agency-wide problem, and it's something that's important to talk about within the agency, because you really need time to communicate. The largest part of the job is not the writing the prescription, it's getting the information. Yeah, right. Sure.
I think I got the microphone.
Oh, here. Okay.
I'm curious if, for children or adults, if the symptoms of bipolar disorder can be managed effectively without psychotherapy or medication.
Okay, question. Can you manage symptoms of bipolar disorder without medication or psychotherapy? People manage themselves all different ways. Somebody can manage themselves by going to church every day. If that can help them keep a stable mood, that's their therapy. That is the therapy. Often, if the illness is severe, they're going to need more help. I mean, it's like saying, can diabetes be managed without medication? Well, sometimes if you manage diet and you exercise, you're going to be able to keep your blood sugar down. But sometimes you're not. If you don't have any functioning islets of pancreatic cells, you're going to need medication. And the same with a disorder of the brain. Sometimes the disorder is function. You can find ways to help yourself, and sometimes you need additional help managing that organ's difficulties. I had a young adult man who was a teacher, and he kept very fine control of his moods during the school year, but he said, during the summer, I don't need to be so controlled. And so he would reduce his medications. And he said, it was a period I wouldn't sleep as much, and I would be much more creative, and I'd be more active, but I would have to watch for periods of severe depression, and if I thought the grass was speaking to me, I knew I better get back on my medicine. So he had a way of monitoring himself that was effective for him. So he didn't need therapy at that point. He really needed somebody to help him sort of figure out what was the dosing at which time and for what reasons. Other people, the point of the therapy is really to help them come to grips with having an illness. It's not that the therapy itself makes it all better. It's just that this young man I was telling you about in another city is profoundly depressed because he's got an illness. And he never had one before. He never felt like it. And now he feels vulnerable in a way he never felt before. And that's what the therapy's for. And no medicine is going to take that sense away. Talking about it is going to help him with that. Sure. Yeah.
Hi. I have more of a curiosity about something. I work with the DD population as well and address what that young woman said. I have two young men who are in their late teens, early 20s, and they were prescribed Thorazine long before I got them. It's such an old medication, and I was wondering, I don't get a chance to talk to the person who prescribed it. Their parents take them. I'm very disconnected from that aspect of talking to the doctor. How do you address for me, why would you use something so old when there's newer medications? Do you ever use it, and why?
Well, I don't use it because I think we have better choices available to us.
Right.
But if somebody was on it and not having problems and it was effective, I wouldn't necessarily see any reason to change it, because you can monitor for side effects. And every medicine we have, even if they're better in some ways, have potential for side effects. So I don't tamper with success.
I didn't want to fix anything that wasn't broken either.
Right.
I don't know if something would work that would be better.
Yes. I mean, it would be a question to ask, and I certainly would raise with the parents, have you asked the psychiatrist if any of the new medicines would be useful in this case? But they may feel like, hey, this is working, I'm not going to play with it, and we're not having side effects. Why would somebody choose Thorazine, for example, is because it's more sedating than most new medications. And if you're trying to sedate somebody because they're overly aggressive, you may be happy with that side effect and not eager to change it. I mean, Thorazine was a useful and it is, it was effective. It's just that it had side effects that were difficult over a long period of time, and some of the new medications have addressed that. On the other hand, some of the new medications have their own problems. So I think that's why, but the only way to approach it really is to get the parents thinking and questioning and wondering themselves. I mean, we don't, medicines don't go away unless they've been proven to have terrible effects that nobody realized. And you're going to find some people are on older medications. What I find is that new residents prescribe new medicines, and you can see what people are on based on what year their physician was trained. because they use the one, oh, this is a new good one, and now it's the one I keep using the rest of my life, and then new good ones come out, and it's only the new people who use them. And one's tendency is to use what you're familiar with, what you're comfortable with, what you've seen being effective. And just because a medicine is new, it doesn't mean it's actually going to be better. Other questions? Yeah. Here it comes.
You said that it's important, or something along those lines, about when someone's on antidepressants, a minimum of a year, I guess is the timeline that you start out with. Why is it a year? Like, what's important about that number?
It used to be the recommendation was, for 6 months. And then what they found through studying, people who have been on medication and stopped it, is that depressions tend to recur when you stop too early, and that there's a better likelihood of less recurrence if you extend the medication treatment longer. So why would that be? What would be the advantage of treating longer? We know that we're affecting receptor sites. Possible there's some change in receptor sites over that period of time that wouldn't occur in a shorter period of time. Does that mean it's not a rule? It's just a recommendation. If people want to stop earlier and they're feeling better, let's say go for it and let's see how it happens. But you should know that sometimes it's harder to get the result if you stop the medication. I mean, it's one of the risks you have to take. Okay, no other questions. Thank you. Stay around for the drawing.